Hi everyone. I'd like to follow Tim's presentation on quantitative analysis methods by introducing control charts, which sit within the wider term statistical process control. This topic is important because in my experience, the most common approach to quantitative analysis used in healthcare settings, which is typically associated with quality improvement programs or service evaluation initiatives, is either control charts or more likely their rogue relative run charts. Their relative merits and the appropriate use of control charts is, in my opinion, in general, poorly understood. Discussing this now may help to inform your understanding of how to promote appropriate analysis. I'm going to very briefly describe the essence of control charts, then comment on the absolute need to avoid using run charts before highlighting the key issue of selecting the right control chart for the data to be analysed. So let's start with the creator of control charts, Walter Shewhart. He was an American who trained as a physicist before spending his career working at Bell Laboratories on quality control methods to improve the manufacturing processes of complex new communication technology telephone exchanges, which they exported around the world in the 1920s and 30s. In 1924, Shewhart published his first paper on new statistical methods of assessing the quality of manufacturing processes. It was based on the insight that every manufacturing process displays variation that can be distinguished in terms of whether the variation is in control or out of control. Processes that are in control are subject to common cause, chance, or random variation only. These processes are stable and show a consistent pattern of variation. In contrast, processes that are out of control display special cause or assignable variation, and by definition, these processes are not predictable and change over time. This insight has proved hugely powerful. His methods were used by the US military during the Second World War before being given to the Japanese as part of its post-war support for economic revival. Japanese manufacturers systematically applied control chart methods and became dominant in international trade over many decades. By the 1980s, control charts started to be used in non-manufacturing industries, including healthcare. This quotation from Don Berwick 30 years ago illustrates how he, as a physician, sought to appeal to his medical colleagues to embrace the use of control charts. He says, use of Shewhart's control charts can successfully reduce each of these forms of variation without insult to the professional autonomy, dignity, or purpose of healthcare professionals. More on Berwick in a few minutes. First, let's start with the basic form of control charts, which is straightforward. We select an important measure of quality, process, or outcome, and plot the data on that measure over time. In this case, the time it takes to commute to work. In a hypothetical example, I'm borrowing from Neil Westwood. Inevitably, there will be variation in the recorded times. We then plot the mean, or sometimes median value of the data, and then we calculate and plot what are called the upper and lower control limits. These limits allow a distinction to be made between common cause variation that occur in the data falling between the control limits and those data, if any, that fall outside the limits, which indicate the presence of special cause variation. In this example, there are three instances of special cause variation which are adverse. And our first action in response to this control chart would be to find out what caused these long journey times and then endeavour to eliminate the recurrence. Of course, we might observe desirable special cause variation, and if present, then we can assess whether we could change the process to make the desirable cause routinely present. Well, we can all appreciate that if, for example, we only had to travel to work in school holidays, then the process would be fundamentally different and improved in terms of this measure. Now, there are a number of other rules which also signify the presence of special cause variation, but we don't need to review those now. For now, the important points are as follows. First, use of control charts instigates specific action. If adverse special cause variation is present, we seek to understand its basis and then eliminate it. If only common cause variation is present, then we can decide whether the performance in terms of mean value and control limits is satisfactory or not. As this quotation from Shewhart states, a process in control can be predicted in terms of its future performance. If satisfactory, then we can move on to another potential measure to assess. If unsatisfactory, then we take steps to make changes to the process to deliver improved performance, which we can then assess using control charts. So the starting point is to select the type of control chart to be used, and this will be determined by the data we wish to analyse. The answers we give to the questions listed here take us to a particular control chart type, or in this case, a choice of types. For waiting time data, I would start by selecting these options in red, including choosing to plot data for consecutive groups of 4 patients each, rather than individual patients, which would lead me to use the pair of control charts called the X-bar and moving range charts. This is an example of these charts, showing A&E waiting target data for OneTrust for a week. We can see that performance improves during the week from Monday through to Friday evening, when waiting times increase and remain comparatively high over the weekend. This is particularly clear from the top chart that shows the mean waiting time for each group of 4 patients plotted consecutively. This guide illustrates how the choices we make relating to the preliminary questions take us to a particular control chart type. I'm emphasizing this now because in a few minutes we're going to see that it is problematic to use the wrong chart type. First, let's start to fast forward in time to when the use of control charts was mooted in the NHS. This was first done by Don Berwick over 20 years ago as part of his collaborative model for service improvement, which his Institute for Healthcare Improvement exported from Boston to the NHS. His basic model, for which I've summarised its characteristics here, is still the basis for national quality improvement programmes in the NHS. In fact, NHS England advocates the use of Plan Do Study Act cycles, small-scale tests of change, as part of Tom Nolan's model for improvement, which is a key part of the legacy of Berwick's collaborative model. The model for improvement asks 3 questions, and they are intended to be addressed directly by using control charts. The questions: how will we know that a change is an improvement, and what changes can we make that will result in improvement, can be answered using control charts, but not run charts. While Berwick's model in theory advocated use of control charts for quantitative analysis, in practice run charts were used instead in the collaboratives. This is a typical example of a run chart for a trust from the first Orthopaedic Services Collaborative. In this case, the aim was to reduce length of stay for total hip replacement cases. It shows baseline mean length of stay of 15 days in the first couple of months, and then lower mean values over the subsequent 6 months, and then a best practice target value of 8 days. We are invited to infer that progress is being made towards the target, but in fact, in the absence of any other information, we can't infer that this chart illustrates anything other than random variation. It certainly doesn't provide evidence that is viewed as credible for changing historical working practices. As this quotation from a lead clinician, a senior oncologist from the first Cancer Services Collaborative illustrates, here this initiative also used run charts rather than control charts, and he says, "My main concern was always the measurement, that we make proper measurements. My concern is how am I going to stand up and talk about something and say to people it's been a great success, or we've engineered this change, if I can't back it up with some good data that I can use to convince others that it's been a useful change." So you may be thinking, why am I illustrating this issue from research undertaken 20 years ago? Well, it's not just that I worked on this evaluation, it's because this issue should be well understood by now, but it's not. If we look at our local Academic Health Science Network's current website, we can see run charts advocated for use in evaluation. And if we click on the run chart word there, it takes us to a following page. And in my view, it is unhelpful that statements like this are made. Run charts are one of the most useful tools in quality improvement because they are simple to make and relatively straightforward to interpret. Yes, they're simple to make, but in isolation, they're certainly not possible to meaningfully interpret. The same website also provides a link to NHS England's Excel control chart tool. It's absolutely super that NHSE took the step of producing this last year. It represents very important progress, but it still falls short in terms of providing appropriate leadership on this topic. Critically, it doesn't pay attention to the requirement to match the data type to be analysed to the appropriate type of control chart. In this case, the tool generates charts suitable for plotting individual cases of variable data, such as waiting time, which is possible, but really only represents a special case. Schuhart would start with plotting data for consecutive groups of patients, as in the example I showed you, rather than for individual patients. Furthermore, the tool doesn't distinguish the type of data by offering the control chart suitable for plotting data represented as, for example, percentages, even though it allows the tool user to enter data as percentages, as I've done here. These data are the weekly percentage of cancelled operations for a trust. The tool's control chart looks like this. It is obviously problematic because it shows the lower control limit as less than 0, which is nonsensical. And it suggests that in terms of special cause variation, indicated by data points falling outside the control limits, that there is only one instance of adverse special cause variation. In contrast, If we plot an appropriate control chart for these data, called a p-chart in this case, we see 3 instances of adverse special cause variation. And most obviously, we see that the control limits are not parallel lines. This is because for this type of chart, the control limits would only be parallel lines if the number of operations in each week was the same, which is of course very unlikely. So to return to the guide to control chart types, in this example we should be here using a p-chart, but instead the NHSE tool is using the formula for a different type of control chart, which is erroneous. So, to summarise the issues, well, clinicians can be motivated to change practice in response to quantitative analysis they view as credible, and research shows this does not include use of run charts. Control charts are now promoted quite widely, but in my experience, they're typically not used appropriately, and as I've highlighted, this includes selection of the correct chart for the type of data. Nevertheless, control charts have important potential as an analysis method, which could be used in support of economic evaluation, for example, to address measures of efficiency, such as operation cancellations. And finally, additional support for those leading and evaluating service change is certainly needed. Thank you.